Welcome to La Via Las Vegas podcast. We're two physical therapists living the life in Las Vegas. I'm Dr. Erica.
And I'm Dr. Joe. We created this podcast for two reasons. First, to connect the healthcare, wellness, and fitness communities in Las Vegas. And second, to highlight all the amazing people we've met along the way.
Thank you for listening, and remember to take care of yourself.
Welcome to the show.
Thank you.
If you'd like to introduce yourself and tell us what you do.
My name's Gibson. I'm a pediatric physical therapist. I work in a mobile outpatient setting, which is, for the most part, going into kiddos' homes and doing physical therapy. But it has a lot of freedom in that we can kind of meet wherever. If they want to go meet at a playground or even do aquatic therapy in the swimming pool. A lot of flexibility, so not just limited to like a home health setting. So.
Very nice. And what brought you to Vegas?
That's a great question. Sometimes I ask myself, how did I get here? I went to grad school in Nashville, stayed there and worked, loved it. But the healthcare field is just kind of saturated there and was looking for better opportunities. Randomly applied out here, but actually had no intentions of coming. Just was like, oh, this looks like a good opportunity. Came out here, was like, yeah, as I thought, I'm not actually serious about that. That was a nice trip, but not going to do that. Went back to Nashville, worked a few months, and couldn't stop thinking about it. And the company kept reaching out, and I was like, oh, maybe I need to give this a try. And literally, I feel like without thought, I was like, if you don't just jump and do this, you're never going to try anything different. So I just literally on a phone call without discussing it with people or thinking too much, I was just like, all right, I'll give it a try. What's the worst that can happen? I can move back. And I kind of came out here with that intention of I'm going to go for a year and a half, and then I'm going to move back. Life never quite goes as planned, and it's almost been 2 years, and I have no intentions of leaving. So, yeah, there was nothing in me that was oh, I want to move to Vegas. It was more I would never live in Vegas. I did a clinical out here in 2015, and there was no Chick-fil-A, and so I was I could never live there because I have to have my Chick-fil-A. Well, they got Chick-fil-A, so that was no longer an excuse. But
And growing, too. There's more.
Oh, they're popping up everywhere. There's a Chick-fil-A on the Strip, so they're everywhere. I feel like there's more here now than there were in Nashville. So, yeah, the other thing I just the appeal of Vegas, people just know the Strip. I think if you don't live here, that's all you see. And being from the South is oh, that is not my lifestyle. It's just not for me. I'm sure other people love it, but not for me. So I don't know. I never in a million years would have thought, oh, I'm going to end up in Vegas. But here I am, and there's so much more to Vegas than the Strip. So.
Yeah, some of the people don't realize. We moved here after going to school in Georgia.
Yeah.
And it's the same thing. Everyone thinks that you live in a casino.
Yeah.
Oh, what casino do you live in? What? That's not a thing. You
well, I do live right beside a casino.
Oh, do you really?
I could walk
okay.
to it. Yeah, I actually had a patient's grandma, when I told her I was moving to Vegas, cry because she was like, what kind of life are you going to live in Vegas? And I was like, I think there's more to it than what we know. Turns out there is, so.
You should invite her out here.
Yeah.
Change your mind. Take her to Chick-fil-A.
Yeah, you should have a great time.
Mm-hmm. So you're in pediatric physical therapy. You want to describe to our listeners what that is and how is that different than working with adults?
Yeah. So it's different in that they don't just do what you tell them to do, but it's so fun. So for the most part, I see kiddos with congenital issues. So I think the question I get most often is people oh, you see a kid who broke their arm and stuff. There's certainly settings where that happens. The setting I'm in, it's more a kiddo was born with some type of genetic syndrome or cerebral palsy or Down syndrome. Kiddos with autism often have coordination issues. So it's a lot of kiddos who are born with things from birth, or kiddos who are just delayed for one reason or another. And so kiddos that are delayed, it's kind of just catching them up on their milestones, like getting them crawling, walking, all the typical things that we don't think that kids, they usually figure it out on their own. Some kiddos don't. Sometimes we don't even have a good reason for it. There's just delay. The kiddos with the congenital issues, it's turns into sometimes more of a lifelong process of helping them meet their milestones, but then as they grow, so much changes. They get bigger, muscles get tighter, you kind of take steps back, a lot of equipment management, and just helping advocate with the families, just getting them the equipment that they need can be such a struggle with insurance. So I feel like there's a lot of case management in pediatrics, and just walking alongside the families. And it's a lot of parent involvement and making sure that, you might go in and see I want this, this, and this for the kiddo. But what's practical for the family? What are they on board with? What are their goals? So it's a lot of working with the parents too. One, to know what do they want for their kiddo, and two, to help them with carryover of everything at home. Because if you think about it, we're with the kiddo for 1 or 2 hours out of the week, and parents are with them all the time. So getting parents hands-on, lots of education on this is how to carry over what we're working on so that your kiddo can be the most successful. The ultimate goal is just for the kid to be as independent as possible and just to be a kid. Sometimes our sessions look like someone from the outside might look and just say, oh, you're just playing. Well, there's a lot more intention behind it, but yeah, that's what kids do. We want them to just be able to do the things that a typically developing kiddo does,
So looking at that, so if someone were to look on the outside, like you mentioned, it looks like they're just playing with them.
Mm-hmm.
And you said there's intention behind it. Can you give us an example of what that would be, or things that you think about that when you're treating a kiddo with, a developmental thing or, some type of thing that you're working on? And what is that people may not realize? Oh, that's the reason why you're doing something.
Yeah. So working on postural control, let's say you have a kiddo you're trying to get them to learn to sit, and they're in this all hunched over position and whatnot, and the kid's sitting there doing their thing, and you have a motivating toy. They're reaching, putting a little coin into a piggy bank, and I think if someone looks at it from the outside, they're like, okay, you're having them reach for a toy because they like the toy, but I'm trying to position things in their correct position so that the kiddo's reaching up to activate postural muscles. We're going different directions to get rotation, because we all know we live our life in we need rotational movement. So it's kind of these fine little things that you almost want it to be so subtle that it doesn't look like you're doing anything complicated. One, because that makes it easy for the parents, but two, I think that's where it comes in with the education to say, okay, yes, he's playing with a piggy bank, but we're setting it up like this to facilitate rotation, to facilitate postural muscles. We got to get his vision on it. Vision is so important, especially in kiddos, and getting that joint attention, interacting with an adult. So there could be 10 different things going on with one simple little play activity. So
you definitely use a lot more of a skill set, I think, too, doing that, because people just assume PTs only do outpatient therapy, which is working on more musculoskeletal, but you're probably doing a lot of neuro stuff with your patients.
A lot of neuro, yeah. A big part of my caseload is kiddos with cerebral palsy. So the thing, if I'm talking to an adult PT, I relate a lot of times, they're similar to a stroke patient in their presentation. So it's almost like a little miniature version. You're doing the same things, that just the way that you're facilitating things might look different, because again, you can't say, all right, I want you to, you can't tell them a specific exercise or thing to replicate. So you do have to have a creative brain, I guess, to figure out how am I going to get them to replicate this movement without telling them to do it.
Could you explain to maybe someone who doesn't know what cerebral palsy is?
Yeah, so cerebral palsy is whenever at birth or before there's an injury to a part of the brain, it could be, the way it presents can be such a spectrum. You could see someone walking down the street and have no idea that they have the diagnosis. It might be something as little as a small foot drop, like they're just not clearing their foot well when they're walking, or they could be very affected. It just depends on what part of the brain and how large the damage was, to the point where they're spending their life in a wheelchair and relying on others to kind of care for them. So it's a very umbrella diagnosis and can look like a wide range of things. So how you treat the kiddo is just going to be based. It's very individualized. So.
And people don't realize too that they'll have to deal with that all the way into adulthood.
They do, and while it's not a progressive disorder, like once you have the injury, it is what it is. But the way it presents changes as you grow, and so unfortunately, it isn't common. Like you see a young kiddo and they're like moving a bit, but then you think like they start to get older, they get bigger, their bodies are heavier, their muscles are getting tighter as they grow, and they can start to look different. So while it's not a progressive disorder, definitely as they grow, they start to have a lot more challenges. So, and that's why I said it ends up being a long-term thing. So maybe they're not in PT their whole life, but certainly off and on, they're going to be in and out of PT. So.
And one of my friends had it, and he was in his 40s when I knew him, and he had to do mobility work all the time, or his gait or his walking would get worse,
Absolutely.
like progressively worse, and he would, you could tell, like watching him walk, that he looked like he either had a limp or something was wrong.
Mm-hmm.
But if he spent a lot of time working on mobility stuff and like doing the things he needed to do, you almost wouldn't be able to tell.
Yeah.
But he says that if he ever gets lazy with it, if he really gets worried about pulling his back, he said he would pull his back like all the time because he would get so tight that he would just like reach for something on a shelf.
Yeah, and it's a real thing. Like, it's just a constant battle. Like I had a kiddo who was sick for a month, so we're off of PT, and then I go back, and it's like we took so many steps backwards, and now months later we're still working to get back to where we were just from that month off. But that being said, like talking about the lifelong part, that is one of the things that I love about PEDS PT is you're with these patients for so long. Like you get to form an amazing relationship. And even the other part of the specific setting that I do, getting to go into their homes and their environments, you get so close to the patients and their families, which is one of the things that drew me to PT was the relationships. And I feel like this setting, it's just like a little extra special. Like you get so close with the families.
What's the average amount of time then you would spend with the patient? I mean, would it be in the years, would you say?
Mm-hmm. And it totally depends on diagnosis and things. But I had a patient back in Nashville that I saw the whole 4 years that I was there. And so you can imagine, like, even though I've been here 2 years, you still stay in contact with those people because you do. Like, sometimes you're there, and this kiddo in particular, like, seeing them before they even receive a diagnosis, and then you're with the family walking through that process together. So it's physical therapy, but it sometimes also ends up being just like a shoulder to cry on for the parent. And there's like sometimes I feel like I'm like a counselor too, because that's a life-changing moment when a parent receives a diagnosis for their kiddo that's they weren't expecting, or maybe they were, but it's still so much to process. So
I would assume too you have to spend a lot of time educating the patients on what's going on with their child. So for us, sometimes the difficulty that you have is getting through the patient. Like for us, it would be like, hey, it takes this long for this tissue type to heal. This is what you're looking at, realistically speaking.
Yeah.
But for what you do, it must be that there's also such a wide range of diagnosis. But to tell the parent, one, that your kid's going to have help for years, and then two, to make sure that they understand even what's going on and that they're on board with it.
Yes, and that I would say that's probably the biggest challenge is when you have a kiddo, and I'm not one to say, oh, well, this is never going to happen. I think parents always need some glimmer of hope, but then you also have this reality check in the back of your mind of like, well, I have a good idea of what the prognosis is for this kiddo. Of course, like I said, there's no certainty. You can never say for sure. But when you have the parents who are like, well, I just can't, like, just once they're walking, it'll be good. And then, like, in cerebral palsy in particular, there's a standardized assessment that we can use that kind of predicts function. And so sometimes have that conversation of, okay, yes, we can't say for sure, but this is what your kiddo is predicted to look like. And if it's not up to parents' expectations, of course, everyone wants their kiddo to run and walk and participate in everything. So having that conversation of we might have to change our expectations of what our kiddo's life is going to look like is, I would say, probably the hardest conversation to have with a parent. And I'm not good at it because it's just not fun.
In the difficult conversation, though, it's important to have it because you generally can see, like, if you're being upset or if you're upset at what's going on or like don't have a realistic idea of something, then you're going to continue on this struggle where
they're never meeting expectations.
Exactly.
Yeah.
Right.
Yeah. It's tough. And the best I can do is like try to point out all of the positives and letting them know, like, your kid is still amazing and your kid still has so many abilities. They just look different than your expectations were, but it's okay. Like, your kid is still awesome.
Mm-hmm. So what's that process to initially start? If you have a kid, for example, and then they see these things, or maybe they go to the pediatrician and things are happening. What's that process like for them to eventually get a PT referral? How they end up working with you?
A lot of times it's if it's a first child, a lot of times parents like don't realize that there's delay or anything. It's when they see their kiddo around other kiddos, or if they have older siblings and they're like, my older kiddos did this at this time. So either they see them compared to other kiddos and realize, okay, we're not quite in the same spot, or it is the pediatrician who says, okay, we should be here and we're not. So the pediatrician will write a script if it's them who recognizes it. If not, the parent calls the pediatrician and just asks for a script to start PT. Or it might be that the parent reaches out to the PT first, and then we just say, okay, let's just get a referral from your doctor, and then we can start the evaluation process. So,
what's something that you commonly see in your practice that you wish more people knew?
I think, like, just seeing kiddos with special needs and things, to me, it's so, it's my everyday world. So in my mind, like, that's the most normal thing to see is kiddos who are delayed or need extra help. And I think just, like, within the community and even schools, like, there's still a separation of, like, oh, that's the special needs kiddo, and there's still some sort of separation. But they're so capable of so many things, and, like, to just be included in activities with typically developing kiddos is appropriate and so good for them. So I just wish that there was more, like, integration of typically developing kids and special needs kiddos. Like, I wish it was more normalized for kiddos growing up to see, like, oh, yeah, this kiddo is in a wheelchair, but we can still interact. Like, there's not a wall between us because we have different forms of mobility. So,
and just to mention, too, you mentioned milestones, and there's certain things that you typically see for a normal developing child. But I guess when should you be like, this is normal to, like, not reach this point, and then what is abnormal?
Yeah, so I guess it kind of depends on the skill. I think the biggest skill parents always look at is walking. So, and I think parents here are like, oh, my kid should be walking by a year. But just like in anything, there's a range, like 12 to 18 months. If your kiddo's walking at 18 months, it's okay. Like, that's not so delayed. So for walking, the biggest thing I think parents look at is if it's after 18 months and your kiddo's like not trying to take steps, then that's a concern. Even sitting up 6 months, if it's a couple months after, that's fine. But if you're, past that 8-9 month mark and your kiddo is not sitting on their own, that would be a time that I would say, okay, let's get a referral. My recommendation, because I'm like, well, why not be proactive, even if it's a little sooner and you're not worried, like, at the very least call and we'll get you a consult. You don't even have to have a evaluation. If you're like, I don't know, we're 7 months and we're not sitting. If you're concerned, we'll do a consult. Let's give you peace of mind or help you out and get started early if you need it. So,
is that typical that people would normally go to the pediatrician first and then the pediatrician would make that determination? Or do people normally reach directly out to you?
Typically, they go to their pediatrician first, I think, because they already have that established relationship. But it's okay to come to the PT first, too, and get a consultation before you have an official evaluation. So,
is there anything that drives you, or maybe a pet peeve, or drives you crazy in certain, because there's so many devices, like strollers and chairs and sitting devices and, certain toys. Is there anything that, from a perspective of a pediatric physical therapist, give us your thoughts?
Oh, I do have a soapbox. Okay, so one thing that I saw very commonly when I worked in a clinic was those delayed walkers. And they come in and, like, they're just not wanting to pull up to stand, all these things. And you see the kids sit, and they've got this posterior pelvic tilt, and they're hanging out. And you're like, oh, you have no core strength. And then you're like, ooh, is there something else going on? And then you start asking the parents questions, and they're like, oh, no, they hated tummy time, so we didn't do tummy time. Oh, but they love their jumper. Yeah, she loves her jumper, so I just always put her in her jumper. And you can't fault the parents for that. Kids don't come with a handbook, but it's container baby syndrome. Like, these kids are placed in jumpers and bumbos and walkers, and they just learn to hang. So then you sit them on the floor, and they're just like, I'm hanging out. And they have no idea how to activate their postural muscles. So, of course, they're not going to stand up and walk. They can barely sit right. So, yes, educating parents on supervised floor time is best. Every baby needs to be on their tummy. If they don't like it, we can find some different ways to do it. You can do it against your chest. You can do it on a boppy while they're awake. We don't want tummy time while they're sleeping. But yeah, just the overuse of equipment. And if you have those things, I think it's fine. Like, everyone has to shower, go to the bathroom. You need 5-10 minutes to, like, put food together. Like, that's totally understandable. It's putting your kids there and you're like, oh, they really like it, so I just left them. They're content. Yeah. And the other thing that happens with those, like, jumpers and walkers, kids usually are in them before they can even reach the floor, and they end up on their toes. And then we're treating toe walkers down the road, which is kiddos who just walk up on their toes, just what it sounds like. So yes, I wish that there was more education, or like parents got a little handbook at birth that says spend time with your baby on the floor, because that's how they get strong and meet their milestones.
So you're talking about kids that are toe walking in PT school. We're able to observe at a clinic, and one of the PTs there was telling me, oh, this kid that's coming in, he's I guess he had some spasticity going on. He's a big toe walker. So when he comes in, just like, watch this kid's gait. And then the kid comes in, and he's walking normal with his mom. And then she's like, hey, I couldn't help but notice, like, you don't seem to be walking on your toes, and you're coming in today. And then the mom explains to us, well, I told the kid if he doesn't walk on his toes today, then he gets a treat. And then the PT asked the kid, hey, could you just walk on your toes and show us real quick? And the kid was like, nah. I don't know if you heard my mom's previous statement, but I get a treat if I don't do that.
That's hilarious.
So the kid thought it was a trick, and he wouldn't do it.
That's funny. Yeah, toe walking is pretty common. And it can be with increased spasticity. So sometimes you'll see it in kiddos with cerebral palsy. It can be just a habit. I can't tell you how many times I've seen like younger siblings watch their older siblings walk on their toes. So now we got a whole family of toe walkers. And sometimes it's not because of increased tone. It's like a cycle of, okay, they were up on their toes. Now their calves are tight. And honestly, the older they get, the more of a habit. So it's harder to break the habit. But when they're young, I've found a lot of times, like, you can tell them to walk foot flat all day, even if they have the range, but it's so ingrained in their motor pattern to be on their toes, and they don't really care the difference. Like, they're like, what do I care if I'm walking on my toes? So it can be a really tough thing to break.
It's interesting what you just brought up is that kids also learn things by watching,
Mm-hmm.
and it doesn't mean that they have like a genetic abnormality or some other thing wrong with them. I've noticed people, I've seen them walk with their toes out or their feet out like a duck, and their kids are doing the same thing.
Yeah.
So I think a lot of that, when people just mistake something for being genetic, but a lot of things can be learned behaviors as well.
Yeah, and that's what I had parents say, like, well, I was a toe walker too, and then you notice the parent still like has an early heel rise, and you're like, well, parent is saying it's genetic, but yeah, they might have just watched you and picked up that habit for sure. And it can also be, it could be a sensory thing too. Like kiddos with autism or without could just have like sensory seeking, and so they want to be up on their toes to get all that input through the ball of their foot. Or they could be sensory avoidant and they don't want much of their foot to touch the ground. So there's not one size fits all to treat that. It just depends on what the cause is.
So what's your favorite cheat meal? You were telling us something before we got started.
Well, there's a couple. I just discovered that I love peach milkshakes. But also I have pupusa Fridays. So I haven't had those two things together, but it's Friday, so it could happen. Yeah, peach milkshakes. I was talking about how I've been anti-fruit and ice cream my whole life. I'm very pro ice cream, just anti-fruit and ice cream. And decided to give it a try to have a more solid box to stand on when I defended why you shouldn't put fruit in ice cream. And that all just crumbled, and I had to accept defeat and humble myself and say, I was wrong. You should put peaches in ice cream.
And what's a
It's
pupusa?
delicious. And pupusas are, gosh, I don't even know how to describe them. It's like a fat tortilla stuffed with cheese and pork and beans. I mean, you can get different things in them, but it's a Salvadorian food that my Salvadorian boyfriend introduced me to, and I can't quit them.
They're amazing.
And what's something you commonly see in your practice that you wish more people knew? Did I already ask that?
You already asked that. You can cut that one out.
Yeah. So what's something you've been working on professionally, personally, physically, or mentally that you're excited about?
Professionally, one of my passions kind of outside of PT is the foster care system. And so my kind of next goal is to just kind of market more and provide more services towards kiddos in the foster care system. Those families have so many appointments to get to. The kiddos have medical appointments with birth parents, caseworkers, and I feel like the families are just like running on empty. So to be able to provide those services in home, I feel like could just be a little breath of fresh air for the families. So incorporating that more into my PT practice is kind of my next goal. So.
I love that. Another question I wanted to ask you as a peds, because we always hear this about W sitting. What are your thoughts about?
Okay, so I don't believe that there is like very solid evidence that W sitting promotes poor hip development, but we do know that that is not like the most congruent position for the hip socket. So for that reason, I say let's avoid it. But even bigger, and something that we do know is true, like those kiddos are doing it to get a wide base of support. And so again, they are just letting their postural muscles hang out So I always say, let's fix your legs. Even if we can't say for sure that this is going to cause you to have poor hip development, we do know that you're not using your postural muscles when you're sitting like that, so let's fix it.
So one of our old roommates, his brother would sit like that, and this is a guy that's like 40. So you'd see him like sitting on the ground, like drinking a beer. You're like, that is really off-putting to see that, because you normally see kids doing that.
Yeah, kids hear me constantly say, fix your legs, all day.
We tried it with him, it didn't work. I think that pattern's pretty ingrained. So what's something that you've learned that you wish you knew sooner?
Something I learned that I wish I knew sooner is probably that it's okay to not know everything. I think especially right out of school, I had a little bit, and probably still do, of an imposter syndrome complex where it's like, oh, but they're going to find out that I don't know all the answers. In peds, what I found that parents appreciate more than anything is that you care. If you don't know something, it's okay. Just be upfront with them about it. Like, I don't know the answer to that. I don't know the best way to approach this, but I'm going to do my best to find out. And really, like, that's what I've learned so much is parents want someone who's going to listen to them and advocate for them, because they are in and out of all these doctors so often, and they're just, like, being told all these things, but so often they're not getting their voice heard. So I think, like, worrying less about, like, oh, I don't know all the answers, but just knowing that it's okay, I can figure that out as it comes, but I can right now be that support for the parent to the best that I can. So.
Mm-hmm. And what would you like to leave listeners with?
I would say, just like we talked about earlier with the kiddos, like, interact with special needs kids. First of all, they're hilarious. Oh, if a kiddo's been in therapy their whole life, I call them therapized, because they've just, like, interacted with adults since the birth, and they are the funniest kids, and usually, like, have great manners. Don't get me wrong, I have a lot of behavioral kids. Right now my caseload feels like sometimes I'm just a behavior therapist. I'm not. So it would just be like, reach out. If you see a special needs kid, like, have a conversation with them. Yeah, I think just interact. Make them, for the most part, like, it's okay to ask questions, but make them feel like a normal kid, because they are. And don't put them in a different category. Go into it thinking that they're so capable of whatever you ask. So.
And how can people find you?
I'm a social media list person, but I have a PT-specific email that's lgibson. I said it all wrong. laureng.dpt@gmail.com.
And we'll put your info in the show notes as well.
Great.
Mm-hmm. Well, we really appreciate you being on the show. Thanks for your time. I feel like we learned a lot. PEDS is something I know very little about.
Well, thank you for having me.
Mm-hmm. Thank you.
Thank you.
We'd like to thank you for listening to La Vida Las Vegas podcast. We hope you enjoyed the time with our guests as much as we did. It would help us out so much if you could share, subscribe, or review our podcast, or any combination of the three. Thanks again, and remember to take care of yourself.